Celiac disease. Etiology, pathophysiology, and pathology. Celiac disease or gluten-sensitive enteropathy is a state of heightened immunological responsiveness to ingested gluten in genetically susceptible individuals. It is characterized by damage of the small intestinal mucosa due to intolerance to a group of proteins present in wheat, barley, and rye. The etiology is unknown but probably requires both environmental and genetic factors. 10–12% of first-degree relatives of an affected individual have the disease. 85–90% of patients carry major histocompatibility complex, MHC, class II markers HLA-DR3 and HLA-DQ2, and the remainder are DQ8 positive. These HLA markers are present in a large proportion of the population, and less than 0.1% of individuals with this haplotype actually develop celiac disease, but it is not possible to have celiac disease without one of these HLA markers. Tissue transglutaminase has recently been identified as the autoantigen towards which endomysial antibodies are directed. Gliadin peptides are rich in glutamic acid residues that are modified by tissue transglutaminase and presented to intraepithelial T cells by antigen-presenting cells via the HLA-DQ2 molecule. Activation of T cells results in patchy damage to the small intestinal mucosa, with the proximal small bowel more severely affected. Changes in the intestinal lining are graded using the modified Marsh criteria shown in Table 31. Epidemiology. Celiac disease was once thought to be rare but has been shown by large screening studies in Europe and the USA to affect 1 in 100–200 people. It is rare in Africa and has not been described in China or the Caribbean. It occurs more commonly in females, 2:1. In adults, diagnosis peaks in the 4th and 5th decades in women, and the 5th and 6th decades in men. NB. Celiac disease may present for the first time in the 7th or 8th decade of life. Clinical presentation. Symptoms and signs. Common. Anemia, iron, folate, or mixed deficiency, often found by chance. Diarrhea, typically pale, bulky, offensive, and difficult to flush. Weight loss and failure to thrive and short stature. Irritable bowel type symptoms, e.g. distension, pain, bloating, borborygmi. Anorexia, nausea, vomiting. Aphthous oral ulceration, glossitis, stomatitis. General malaise, lethargy. Mood change, anxiety, depression. Less common. Infertility and amenorrhea. Bone pain, osteomalacia, osteoporosis. Dermatitis herpetiformis. Rare. Neurological, peripheral neuropathy, cerebellar ataxia, etc. Tetany, hypocalcemia. Rickets. Bruising and night blindness, deficiencies of fat-soluble vitamins A and K. Constipation. NB. The diagnosis of celiac disease should be seriously considered in any patient with diarrhea and steatorrhea or with iron or folate deficiency anemia. Investigation. The most important issue is to have a high index of suspicion for the diagnosis. Blood tests. An FBC may show anemia, iron and/or folate deficiency, and the blood film a dimorphic population of red blood cells with Howell-Jolly bodies, associated hyposplenism. Occasionally there is isolated B12 or folic acid deficiency. Some newly diagnosed patients have raised transaminases, but these usually normalize after treatment. Serology. Anti-gliadin antibodies are commonly present but have a lower sensitivity than other serological markers. The combination of anti-endomysial antibody, anti-EMA, and anti-tissue transglutaminase antibody, anti-TTG, has a sensitivity and specificity above 95%. Some patients have an associated IgA deficiency that can render these tests negative as they are IgA-based. However, one of the anti-gliadin antibodies is IgG-based and there are IgG versions of anti-EMA and anti-TTG. Histology. Histological examination of small bowel biopsies remains the gold standard for diagnosing celiac disease, and should be performed if the condition is suspected whilst the subject is on a gluten-containing diet. Previously jejunal material was obtained via a Crosby capsule, but now the standard technique is to obtain 4 duodenal biopsies because of the patchy nature of the intestinal findings. Barium follow-through. This is often abnormal but is not usually needed to make the diagnosis. The normal fine feathery appearance of the mucosa is replaced by a coarser pattern, transverse barring, or a tubular featureless appearance in severe disease. Differential diagnosis. If diarrhea, giardiasis, infection, inflammatory bowel disease. If abdominal pain and or weight loss, Crohn's disease and thyrotoxicosis. If steatorrhea, exocrine pancreatic insufficiency. If iron deficiency anemia, consider other reasons for blood loss. Other causes of villus atrophy include giardiasis, hypogammaglobulinemia, bacterial overgrowth, tropical sprue, cow's milk sensitivity, Whipple's disease, lymphoma, and NSAIDs. Treatment. Gluten-free diet. Strict withdrawal of gluten from the diet is advocated. 85% of cases respond to this and relapse on its reintroduction. Physicians and dietitians should be involved in educating the patient about the condition, and membership of Celiac UK encouraged. Compliance can be assessed using serial antibody measurements, which usually diminish once gluten is withdrawn from the diet. The small intestinal mucosa may take many years to normalize, if at all, and therefore routine follow-up duodenal biopsies may not be useful. NB. Persistence of anti-EMA 6 weeks after starting dietary therapy suggests non-compliance. Dietary supplementation. Iron, folate, vitamin D, and calcium supplementation may be required at diagnosis depending on the degree of abnormality and symptoms. Non-responsive celiac disease. Some patients do not respond adequately to a gluten-free diet, and this may indicate the presence of associated conditions or complications. The most common reason for continued symptoms in celiac disease is continued gluten exposure, and therefore reassessment of the diet, perhaps best performed by a dietitian, is essential. Associated conditions include exocrine pancreatic insufficiency, up to 1/3, new thyroid disease, 1–2%, and lactose intolerance. Alternatively, one of the complications may have arisen. Immunosuppression. In those patients who do not respond to dietary treatment, steroids and other immunosuppressants, such as azathioprine, may be required to induce remission. NB. Important information for patients. Symptoms of celiac disease are usually relieved and complications reduced by permanent adoption of strict gluten-free diet. Join Celiac UK. Complications. Bone disease in up to 40%, osteoporosis and osteomalacia. Increased risk of gastrointestinal malignancy, enteropathy-associated T-cell lymphoma, squamous cell carcinoma of the pharynx and esophagus, and small intestinal adenocarcinoma. Hyposplenism, common and related to duration and severity of disease, but rarely causes problems. Ulcerative enteritis, a rare complication that may be an early manifestation of malignant lymphoma. NB. Osteopenia and osteoporosis are relatively common at diagnosis, but malignant complications are rare. Prognosis. Mortality. Mortality is increased in celiac disease, chiefly due to an excess of malignant disease. Adoption of a gluten-free diet appears to protect against this complication and results in a normal lifespan. Disease associations. Associated diseases are shown in Table 33.